Very good afternoon, everyone, and welcome to this, to our weekly teaching. We had a nice break last week, but I think it was packed with a lot of, academic activities from SIOP. So today, it's a very common and very interesting topic. We come across it every day in our day-to-day practice. So we're going to be having a seminar today on mucositis, and you must have seen we have changed a little bit of pattern in these teaching sessions. There are going to be few seminars in between the case discussions we have been doing all this while, and we had a very exciting session a couple of weeks ago, which was on flow cytometry. Now today we'll be discussing another very common topic, which is going to be mucositis. Now, I know I don't need to introduce the mentor and the moderator today. Professor Amita Trehan ma'am is going to be the mentor for and moderator for today's session, and she doesn't need introduction to this audience. She's one of the most senior members of the PHO community. She is presently the professor and head of pediatric hematology-oncology at PGI Chandigarh. She's also the chairperson-elect of the PHO chapter. So thank you very much, ma'am, to dedicate this time today with the students. I know you're very busy at your center, so it's very nice of you to get out some time to be interacting with all the students today. Dr. Srinivasan is going to be the presenter. He's a DM resident at PGI Chandigarh, and he's going to be talking on mucositis. So thank you once again, all the program committee who puts this all together, especially Neeta and Anand, who kind of work very closely to coordinate these sessions. Over to you, ma'am.
So thank you, Sunil and the PHO team. These sessions are, I think, very well welcomed and are extremely well put up. So first tiny correction. Srinivas has finished his DM and is actually the chief senior resident. So just for all, that he's a reasonably senior young man.
Oh, sorry, ma'am. Thank you.
No, it's
Thank you
okay.
for that correction.
Just by the way. And so we'll go on to, so mucositis, I think we all know, Sunil has already said, is a very important day-to-day issue in supportive care. Complex phenomena, involves a wide variety of cell and tissues of the oral mucosa. And the spectrum can be from a very mild mucositis to we see very severe ones. So, and obviously this is a result of all the toxicity we are doing and seen in chemo as well as much more in the transplant situation. But with high dose chemotherapy, we see it very frequently. Now, I think the purpose of this seminar is number one, that we recognize it, treat it, and what all can we do. There are some things which are easily feasible, some things which we read about but we know we cannot do. And we also need to remember and recognize that mucositis is a portal of entry for your normal commensals in the mouth and gut, and which can lead to bacteremia and sometimes life-threatening sepsis. Of course, and we should not forget that things like mucositis end up affecting your quality of life. It increases your hospital days, adds on to admission, and obviously that translates to economic consequences in increase in inpatient charges. So with this, I request Dr. Srinivas to start his presentation. And everybody, please keep your mics muted so there's no interference. Thank you so much. Over to you, Srinivas.
Thank you, ma'am. Am I audible, ma'am? And my screen
Yes.
visible?
Yes.
Okay, thank you. So good evening, everyone. So I'll be presenting a small seminar on mucositis management. So thanks for Dr. Amita Trehan in guiding me in making this presentation. So the main outline of my presentation will be mucositis management, a bit on definition, pathobiology, differential diagnosis, and clinical consequence of mucositis, and more emphasis on grading, prevention, and treatment with a special focus on basic oral care. And there are, if you go to literature, there are variables, things and the literature on laser therapy, cryotherapy, growth factors, anti-inflammatory agents, cytokines, natural agents like honey, antimicrobials, coating agents like sucralfate. But discussing all these will be beyond the scope of this seminar. So I'll be just running through current recommendation of these agents, if anything. So with this, I start. Master VS, 7-year-old male, known case of precursor BALL intermediaries. He was on capacity interim maintenance. We all know that in capacity interim maintenance, one gets IV methotrexate in escalating doses. So he got 200 mg per meter square of IV methotrexate. On day plus 9, he came with a painful mouth ulcers and difficulty in swallowing. So diagnosis here is quite simple because of the background history of ALL, received methotrexate, and now on day plus 9 he came with some painful mouth ulcers. So it is oral mucositis. So usually the mucositis presents, it can present very early also, but usually once the child receives any chemotherapy which can cause mucositis, any any day from day plus 5 to day plus 14, they can present with severe mucositis. One should be anticipating these kind of problems. So coming to the definition, so it is an inflammation or damage of the mucosal lining of a part of or of entire GI tract, characterized mainly by erythema, painful ulceration examination, and sometimes pseudomembranes. So it's broadly categorized into two different categories: oral mucositis and GI mucositis. Oral mucositis is the one when we pick up very easily and early because they present predominantly with the symptoms of pain, difficulty in eating, swallowing, and speaking. Whereas in GI mucositis, because it can be compounded with other etiologies, they present with non-specifically, usually with the nausea, vomiting, and diarrhea, bloating sensation, intestinal cramps, and pain all along the GI tract. So, as Mamas mentioned, it's a frequent complication following chemotherapy and radiotherapy, especially when someone gets head and neck radiotherapy or combination of both in the hematopoietic stem cell transplant setting following high dose chemotherapy and total body irradiation as a part of conditioning regimens. So the burden of mucositis is quite high. If you see only with chemotherapy, it may be seen in up to 40% of the cases. In HSCT setting, it may even go up to 70 to 80%. When we receive exclusive radiotherapy to head and neck region, the incidence may be even higher, reaching up to 100%. That is, almost all of them may receive some form of mucositis. So before going to topic proper, so I would like to just give a brief on stomatitis. So it is an entity which involves infectious or inflammatory complications of oral mucosa. Together put up, it is called as stomatitis. So it can range from simple aphthous ulcers to debilitating necrotizing ulcerative stomatitis or gangrenous stomatitis, and also oral thrush, herpetic stomatitis, or oral mucositis. So while dealing patients, oncological patients, when they are on chemotherapy, one should have a broad differential diagnosis. Sometimes it could be a differential diagnosis of oral mucositis, or sometimes it can be a combination of both, like oral mucositis with super added infections. So why it is so important to differentiate it from oral mucositis? As we can see, the causes, clinical features, and severity and treatment options are different for all of them. So the after ulcer, sometimes it could be single or it could be multiple. It will be usually very painful, but not maximum to degree of grade 2, which can be ameliorated with simple topical analgesics. So in other cases, the oral thrush, usually it will be painless to mild soreness with the whitish plaques. And again, it will be usually maximum to grade 1 to 2. And the treatment for the same is a topical or depending upon the severity, oral fluconazole. And there are other conditions like gangrenous stomatitis, necrotizing ulcer with stomatitis. These are super bacterial infection. They can be very debilitating. So they warrant IV antibiotics per se. So it is essential to have a differential diagnosis while dealing with oncological patients, especially one suspects mucositis. Because for the mucositis, most of the time it will be once it sets in, it's a supportive care. One has to differentiate whether the child is having underlying bacterial infection or not. So these are the common drugs which are implicated in mucositis in pediatric cancer, which includes anthracyclines, daunorubicin, doxorubicin, methotrexate, could be IV or simple oral methotrexate also can cause mucositis. High doses of melphalan used in conditioning regimens in auto and allogenic settings. 5-fluorouracil, high dose cytarabine, etoposide, cisplatin. These are some of the common drugs. I'm just listing it. So as we know, the common site for mucositis is oral mucosa. This is the most frequent site. It is most commonly picked up, and it's picked up usually early. Whereas GI tract, because they present with some non-specific symptoms, sometimes we may tend to miss mild degree of GI mucositis. Though the mechanisms are similar for both, because usually GI tract mucositis is diagnosed a bit late, they can cause more damage when compared to oral mucositis if you miss it. So coming to mucositis mechanism, so a brief on mechanism so that one can have an idea of what are the possible targets to prevent or treat the mucositis. So they target mainly the mucosal tissue, the basal cells of oral mucosa, and even submucosal tissues following chemotherapy or radiotherapy. So this is the normal mucosa with epithelium. With epithelium, this submucosa which has various tissues like fibroblasts, macrophages, capillaries, and extra cellular matrix. So, to our conventional understanding, what we always think is following chemotherapy or radiotherapy, they may have a direct effect on oral mucosa and it causes mucositis. So, when we actually go back and see the mechanism, it's actually the inciting phenomenon is usually from the submucosal region. So whenever an individual gets chemotherapy or radiotherapy, it induces the submucosal tissue, especially endothelium or stem cells in the basal layers of the mucosa, thereby causing inflammatory cascade and leads to destruction of epithelial cells, forming ulcers. So the normal GI mucosa contains various microbes which can sometimes simply colonize the mucosal area and then cause colonization, or it can translocate and permeate these barriers and then reach the blood vessels and cause bacteremia, sepsis, and even multi-organ dysfunctions. So if it has been intervened at a proper time with adequate supportive care and antimicrobials, if the underlying infection is there, then it starts healing on its own during the natural course. Usually it may take up to 2 to 3 weeks for complete reepithelialization and thereby healing. So this is a picture showing various phases of mucositis. This is a phase one. Once the individual gets chemotherapy or radiotherapy, there will be injury to the mucosal and submucosal tissues, followed by there will be a wide cascade of inflammatory reactions, which will get amplified and then leads to ulceration, and finally the phase 5 of healing. So because there are so many inflammatory mediators which are involved in causing mucositis, so there are a lot of studies going on identifying these inflammatory markers as for diagnosis and also as a potential target for prevention and treatment of mucositis. Because once if we can identify these inflammatory mediators, we may even halt the progression of the mucositis. But till yet, there is none of the agents has been proven very beneficial in preventing mucositis completely. And as there are multiple inflammatory mediators, when we want to target, it is quite understandable that there is no single agent which can be used to target and prevent or treat this mucositis. So what does this mucositis cause? What is the clinical consequence of this mucositis? So an individual can have inability in eating, drinking, speaking, swallowing, sleeping. So one should always remember that severe mucositis should always be considered as an oncological emergency, especially when it's like severe grade 3, grade 4. So what is the clinical consequences it has on healthcare related parameters? So we all know that mucositis is usually associated with pain. So use of opiates will lead to excessive consumption of opiates by the individual, need for hospitalization, and increased need for health related resources. And because once they get mucositis, it may take some time for healing. So there will be definitely chemotherapy delay. If sometimes it is life threatening mucositis with infections, then we may need to alter the chemotherapy regimen or stop the inciting agent which has caused those life threatening events, thereby impairing the oncological outcomes. And because the mucosal barrier is breached, there is a high chance that Colles bacteria can permeate and then cause systemic infection. So when compared to individuals without mucositis, the individuals with mucositis has 2 to 3 fold increased risk of infection and need for IV antibiotics. And during that period, if the mucositis episode is prolonged, one might need transiently total parental nutrition also. Last but not the least, it has a severe impact on quality of life. We can just imagine if the child is having mucositis for 1 week to 10 days, so much of pain they will undergo, and inability in eating, speaking, which all hampers the quality of life. And if it is very severe, it can even lead to mortality, which will be fourfold higher when compared to children without mucositis. So this is the reason it should be considered as an oncological emergency and should be dealt whenever we come across. So with this background, we'll go into few case scenarios. So as most of our patients with mucositis receive some of the common drugs which are used in pediatric cancers, like high dose methotrexate is a common drug used, and following which we see a lot of mucositis cases. So high dose, anything more than 500 mg per meter square is called high dose methotrexate. It is commonly used in routine ALL protocols in NHL, which include bucket lymphoma, lymphoblastic lymphoma, DLBCL, ALCL, and osteogenic sarcoma. There are various dose-limiting toxicities of methotrexate. Mucositis is one among them. So going to case, Master AJ, 8 years, known case of TALL in remission, has been admitted for now high-dose methotrexate course 1, which is we give at 5 gram per meter square as per protocol, which we follow is I cycle. So there are some prerequisites that one need to consider before giving high-dose methotrexate. This we all know. Just to emphasize, one has to hold the septron because the mechanism of action is again the trimethoprim. It inhibits dihydrofolate reductase. So there will be increased chance of methotrexate related toxicity when we use septron concomitantly. So it should be withheld at least 1 week prior, and the individual should be free of infection or any mucositis previously the child had, and resolved diarrhea. One should not actively give high dose methotrexate when the child is having ongoing infection or just recovered from the infection, and ensure adequate neutrophil count or platelet count and RFTs and LFTs as per the protocol. And while giving high dose methotrexate, as we all know, we take some of the preventive measures, which is the hydration, which is of paramount importance, and it should be ideally given with alkalized fluid to alkalinize the urine, thereby making the urine pH of at least more than 7 before giving high dose methotrexate. And after giving high dose methotrexate infusion, it has to be followed with leucovorin rescue as per schedule to decrease the subsequent toxicities. While the child is admitted for high dose methotrexate, one has to meticulously monitor, which includes both clinical parameters and some laboratory parameters. So in the clinical parameters, one has to look for, sometimes the child may get very early mucositis. So always look for oral mucosa and check if the child is developing mucositis while admitted. And also for urine output, because the methotrexate is cleared through the urinary route. If the child is having already certain nephrotoxicity, it may be clinically evident in the form of decreased urine output. And lab parameters as per the schedule, as one might need to monitor serum creatinine and serum methotrexate level. So I continue with a small note that prevention is always better than cure. This applies to mucositis very well, because once mucositis sets in, it's largely of supportive care, and it can be very life threatening. So in this child, fortunately we had a methotrexate level monitoring. So as per iCycle protocol, the methotrexate levels are monitored at 24 hours following the initiation of methotrexate, and also 42 hours following the initiation. And serum creatinines as per protocol and urine outputs throughout the hospital stay remained well, that they were within acceptable limits. So it has been planned for discharge. So this is the most important thing of the whole mucositis management. So one should give adequate discharge advice, which includes basic oral care, which is of paramount importance in maintaining oral hygiene. So which we often tend to overlook, and we do not give complete advices. So though it includes multiple things, it's a bundle of care. At least we should try to follow few of things which is feasible and which can be done in day-to-day practice, and also explain them always about the nature of the drug which can lead to mucositis, and always to review back the moment they feel there is a signs of any mucositis. So in the prevention, the most important thing is basic oral care. So what is the basic oral care? It's basically performed by a patient or a care provider to provide comfort, keep oral cavity clean, moist and healthy, and reduce bacterial load or colonization in the oral cavity, thereby decreasing the bacteremia. So how to do? So there are some of the do's and don'ts to maintain, to give basic oral care and maintain adequate oral hygiene. So all of them may not be able to be followed, but at least you have to reinforce some of things to be done regularly and meticulously, which includes regular brushing. Typically, we advise our patients to brush teeth at least twice a day with the soft bristle toothbrushes like kids brushes. So usually this Johnson's brushes, these are made up of nylon bristles, which are very soft, which may not injure or cause pain while brushing. So we have to advise regular brushing and floss once a day. So it may be difficult for younger children, maybe for older children or adolescents, we can advise even with simple toothpicks, they can just clean the uh, any debris in between their teeth or gums. And if it is very small kid, if they have any small amount of any mucosa or any plaques, which can be appropriately cleaned by the caretaker using small gauze, sterile gauze or wrapper on the finger and then clean it. And one more important part is rinsing or gargling, which could be done simply with the warm water or salt water or some buffer solution, which I'll be dealing in subsequent slides, which is also very important. And the child should be encouraged to have soft diets. And if there is any mucositis or any lip cracks, advisors suggest them to use lip moisturizers so that they will not have increased cracks or pain. And also to ensure adequate hydration, we request them to have plenty of water or liquids if possible wherever the dietitian should be involved, so that they can support them and guide them in having the type of foods that they need to have during the course of methotrexate phase. So there are few important don'ts that one should follow. This like one should never order any commercial mouthwashes from the shops, because there are a lot of mouthwashes which might have alcohol in it. So alcohol based mouthwashes can potentially harm the patient. In fact, they can cause more pain and uncomfortable to individual. And moreover, people tend to use chloroxine based mouthwashes, which was shown in various studies. It doesn't prevent mucositis, though its role in decreasing the infection is still debatable. And there is no role of any prophylactic topical antimicrobials. And we should tell them to avoid any rough or crunchy food items like chips and toast, which again can cause microtrauma or pain. And to avoid hot spicy foods or acidic foods, and hot tea or coffee. Cold things can always be encouraged, and avoid fizzy drinks, and over the counter painkillers should be avoided. So coming to mouth rinse, so it is essentially done to remove any visible debris within the mouth and to keep the oral mucosa moist and clean. So there are various commercially available solutions used for this purpose, like easy to treat, which is somewhat slightly less costly when compared to cafosol. So, or we can even advise them to use simple salt water. This is the easy way to make these solutions. Add 1 tablespoon of salt to a glass of water, and which can be used for mouth rinsing. So typically it should be done at least before and after meals and at bedtime, if possible, at least 4 to 5 times a day. Or another preparation is one can use salt, 1 tablespoon of salt and baking soda in a glass of water and use it. So it is again difficult in very young children. Maybe for older children and adolescents, one can always advise so that they just swish it and then spit it out. So it should be kept for at least 30 seconds to 60 seconds and then they can spit it out. So Cafasol has been introduced into the market, claiming it better in preventing mucositis. But in various studies, there is no added benefit using Cafasol. Moreover, it is costly. It will add to the cost of the treatment every day by at least 1,500 to 2,000. So this one more commercial preparation is available in market is Easy Treat, which when can be procured, can be used. It costs around hardly 100 to 120 rupees per pack. It contains two vials. One contains a phosphate buffer, another contains chloride buffer. It has to be mixed together and then rinsed and then had to be spit out. But one has to remember that it has to be done at least 3 to 4 times. It will also again more or less add to a cost in especially in very poor patients. So what are the recommendations for other modalities apart from this basic oral care? So we know that basic oral care is key in preventing mucositis. These are the other three modalities which was found to be of some beneficial in preventing mucositis. So the recent POGO 2017 guidelines, these are the three modalities: cryotherapy, low-level light therapy, and keratinocyte growth factor has been found to be beneficial in preventing mucositis. So remember that there is no other intervention currently recommended for the prevention of oral mucositis Various agents has been tried for the same purpose, which includes GCSF, GMCCF, topical vitamin E, TGF beta 2 solutions, chewing gums, chlorhexidine, sucralfate, but none of them has been found to be beneficial in preventing. So these should not be recommended. So coming to these three things: cryotherapy, low-level light therapy, and keratinocyte growth factor. So POVE has given a weak recommendation because most of the results and studies are from adults, and there is only limited pediatric specific evidence, but it has been found beneficial. So they recommend with a note that it's a weak recommendation. So cryotherapy can be given especially to cooperative children in the chemotherapy or HSCT setting with a high risk of mucositis. So it has been promoted, or it has been recommended because it is very easy, cheap, and but it is applicable only for older children, because in this cryotherapy one typically uses ice cubes or small chips which has to be held in the mouth just before giving chemotherapy. So maybe for very small kids it's not possible, and especially it's also possible only for the chemotherapy drugs which has very short infusion time, because if it has long infusion time there is no benefit, and one has to hold this ice for a longer duration of time. And one more entity that has been found beneficial is low level light therapy. It is nothing but a laser therapy which makes use of only a lower energy levels, so it will not harm. So the other laser therapy that we use routinely for photocoagulation, it has a high energy, it can cause tissue ablation and necrosis, whereas here the amount of energy that is utilized is very low. So I'll not be going into details of mechanism. It has been found beneficial in preventing mucositis. However, one has to remember that it needs a special equipment and expertise to provide this laser light therapy. And cost effective is not very clear whether after giving low level therapy, whether it is actually translates into clinical outcome in preventing mucositis is not very clear. And coming to keratinocyte growth factor, it has been recommended that the paliformin can be used, especially in HSCT settings with a high rate of mucositis. Again, cost and availability is a limiting factor, and there is no any long-term follow-up data or efficacy or toxic data in children. So these are the various laser equipments that are available. So it's a special equipment where one gives this laser therapy in the whole of oral mucosa. Most of the studies has used intraoral route, that is they just apply laser light which covers whole of the oral mucosa. One can also give externally, um, but again it is not possible for young children because they may not be able to cooperate for so long time. So going with case again, so the same child now admitted for second course of high dose methotrexate. At 24 hours from the initiation of methotrexate, we measured his serum methotrexate, which was alarmingly high, and his serum creatinine also has jumped from zero 0.7 to 1, that is more than 25% from his baseline. So what to do? So we all know that at 24 hours after the initiation of methotrexate, we monitor with methotrexate, serum creatinine, and clinically for mucositis and urine output. The moment we see clinical mucositis sets in or create rises by more than 25% from the baseline, if serum methotrexate is available in one center, if it is beyond acceptable limit, that is at 24 hours, if it is more than 150, one has to immediately increase the hydration. So typically we give hydration at 125 ml per meter square per hour, which has to be increased to 200 ml per meter square per hour. And this is the monitoring chart that we follow as a part of iCycle protocol. So you can see it's like a timeline. So initially one has to monitor at 24 hours after the completion of methotrexate with both serum methotrexate levels, clinical examination for mucositis and urine output, and with serum creatinine. So if it is within the acceptable range, then one might just continue same amount of fluid and repeat the methotrexate level at 42 hours. If it increases beyond the acceptable limit, then one has to increase the hydration first and repeat methotrexate level after 12 hours, that is at 36 hours, and see that if it is, sometimes they just catch up with hydration also. In most of the cases, when we hike based on methotrexate level or creatinine, they just catch up and the methotrexate level comes down by 36 hours or 42 hours, sometimes even 48 hours. So one has to follow this table meticulously if we are using serum methotrexate levels and act accordingly. and look for any need for replacement therapies. So this trial, as we have increased the hydration from 125 ml per meter square hour to 200 ml per meter square hour. At 36 hours, his methotrexate levels has reached within the normal therapeutic range, and at 42 hours levels also within therapeutic range, and his serum creatinine has come down to normal level, and in urine output has been remained satisfactory. There is no any clinical evidence of mucositis. Probably here the increase in hydration might have worked, which has led to normalization of serum methotrexate levels and creatinine. The same child after discharge, now he comes back on day plus 7 with the complaints of multiple small oral ulcers with pain, associated with throat pain also, but is able to take both liquids and solids as of now. So what is the grade of mucositis? What to do now? So what are the preventive measures that we have taken? Despite that, now he has developed mucositis. So now, while managing mucositis, so to categorize which form of therapy they need, we have to see whether they fits into low risk or severe grade of mucositis. For that, we need to grade the mucositis and then react accordingly. So coming to mucositis grading, so typically two grading scales are used. One is a WHO oral toxicity scale, and the NCI common terminology criteria for adverse event scale are used. It is a bit easy to use WHO oral toxicity scale, so one can follow either of them. So in the WHO oral toxicity scale, it consists of 5 grades. Grade 0 is normal, and from grade 1 to 4, we can grade depending upon the clinical features and his ability to take feeds. If one has simple soreness or erythema over the oral cavity, it is classified as grade 1. If they develop visible ulcers, but however the patient can take both solids and liquids, then it is grade 2. If they have extensive or severe ulcers with pain and erythema, and they cannot take any solids, but still they are able to accept liquids, then it is grade 3. If nothing is possible through the mouth, that is they cannot take either solids or liquids, then it is grade 4. So together grade 3 and grade 4 are called as severe mucositis. So you can see this is only erythematous lesion, grade 1, whereas they start developing ulcers, but our oral alimentation is possible in grade 2 when it is extensive and painful. So there may be limitation for solids. They may be able to take only liquids in grade 3. When it is so severe, they cannot take anything permoral. So the NCA CDCC also is more or less similar, except for the different definition. Even the grade 3, grade 4 here, they present with severe pain or life-threatening consequences which interferes with oral intake. So now we are going to manage a case who has developed already mucositis despite preventive measures taken, all the possible preventive measures taken. So with a small note that once mucositis sets in, it's largely a symptomatic and a supportive care. There is no single specific agent which can be used in mucositis to treat it. It is a combination of various supportive care measures. So in this child, because he had multiple ulcers, but he's able to take orally, the WHO, he falls under WHO grade 2. So we have to provide adequate supportive care. So what is the supportive care that can be provided for low to moderate grade of mucositis, that is grade 1 to grade 2? One has to continue the basic oral care that has been reinforced and maintain adequate hydration. In these kind of patients, one may prophylactically put NG tube and ensure adequate hydration and encourage high protein diet. And for pain, we may do various measures like local application of analgesics. So we commonly use Dolagel, which consists of two substances in it. One is choline salicylate, which is an NSAID. So it decreases inflammation, thereby local erythema, swelling, and pain. And it also has a component of lidocaine, which acts as a local anesthetic agent. So these agents, agents, they coat the oral mucosa, and they cover the nerve endings and thereby decrease pain. And for especially when we cannot apply Dolagel throughout the mouth, if somebody is experiencing throat pain, they may be having even mucositis down the oral mucosa, that is maybe they are having in esophagus. So one can use mucin gel syrup, which again has anesthetic oxytocin. For older kids, one might even consider viscous lidocaine, which can again be taken in the mouth, and one can just swish and then spit it out for the pain control. So though the weak opiates are not a routine recommendation for a moderate grade mucositis, one can use oral opiates like tramadol on a specific basis. And one has to explain them danger signs that it can even progress to severe grade of mucositis. And one should have a regular visit to hospital and see whether the mucositis is improving or worsening. So these are common agents that are used for treatment of mucositis. So these things, they just coat this ulcerated area. So thereby they prevent the nerves getting stimulated and inhibits pain. So these children, we started him on some local measures, but despite that, on day plus 4, he came now with extensive, painful oral ulcers with mucosal slough with bleeds. We can see that he has bleeds also over this mucosa, and he also has a difficulty in opening mouth and drooling of saliva, indicating that he is not able to swallow his own saliva. Means he is in severe degree of pain. However, he did not have any fever. So, what would be the grade of mucositis and what to do now? Now, because now he has extensive ulcers and he is unable to open his mouth and swallow his own saliva and unable to take both liquids and solids, so he will fall under grade 4 mucositis. Again, one has to continue meticulous supportive care. So when we come across the patients with severe degree of mucositis, one has to examine the oral cavity completely, because it may not be simple mucositis. Sometimes it can be superadded bacterial or infections, or they may have some other fungal infections like oral thrush, or it could be sometimes the color of the mucosa and the odor may give clue towards the underlying any superadded bacterial infection, which sometimes come across the mucosa becoming somewhat darker in color, blackish or brownish, indicating some gram-negative infection superadded. So one is to examine the oral cavity thoroughly and check vitals for volume status, because they might be in severe pain. They might not have anything orally. Every chance that they will be volume depleted, they might be dehydrated. So assess volume status, and the baseline blood counts and the biochemical parameters has to be obtained. So when they present with severe mucositis, always look, this should be an ongoing process that we have to reassess the patient whenever we come in contact with him, maybe twice or thrice a day, and look for any need for IV antibiotics, because there will be grossly breach in the mucosal barrier. So there we having very high chance for sepsis. So coming to the treatment of mucositis in case of severe mucositis. So there are various compartments. So I'm broadly dividing them into three main categories. One is hydration, another is pain control, and there is oral decontamination. So in hydration, especially when child present with severe mucositis grade 3, grade 4, so they have to be provided inpatient care always. So admit the patient as soon as you come in contact with, start him on IV hydration. In the subsequent course of time, if the child is to be kept for nil per oral for more than 6 to 7 days, one might need to have in mind that the child might need a TPN. And if the mucosity is like settling in trend and pain is like better, one might start elementary feeding with a softer liquid diet once it tolerates. So coming to pain management, one has to continue all the possible pain alleviating measures, which may include both topical, systemic analgesia, transdermal, patient control analgesia, which may not be possible in most of the settings. So most important thing is be liberal when you are using analgesics. Don't try to curtail the analgesia dose just for the sake of anticipated toxicities. So we should provide pain relieving agents in such a way that the child should be as much as possible pain free. And once the pain is better and adequately hydrated, and oral decontaminating procedures can be taken up, which includes like one can simply remove the whatever the possible oral mucosal flakes or debris that is possible in a small kids by putting a gloves and then having a sterile gauze, and then we can just clean it. If in older children, one might once it tolerates, one might give them oral mouth rinses, so that it will loosen the mucosa, which prevents adherence of mucosa and causing excessive pain. Though there is no any single recommended agent for oral decontamination, one can simply follow the oral rinsing procedures once it tolerates. And again, reinforcing that always watch for infection and need for IV antibiotics. It should be an ongoing process. So few important important don'ts, especially in severe mucositis, is there is no urgency for putting nasogastric tube, especially when the child is having grade 3, grade 4 mucositis. So because they'll be already having pain, they can be having underlying cytopenias, and the mucosa may be very thin and friable. So every chance that you are going to cause more harm and pain and bleeds, or even very rarely perforation. So always wait for putting NG tube, especially in severe grade of mucositis. And also do not start aggressively enteral nutrition. Give some time, give pain relieving measures, and then give some hydration, and then maybe once he is better and tolerates, one can start nutrition. And avoid anti-motility agents or antispasmodic agents, which is some more harmful, because they can cause bowel stasis and lead to toxic megacolon if the child is having severe GM mucositis and with underlying infection. As mentioned earlier, avoid commercial mouthwashes because they're all most of them are alcohol based, and they'll be causing more irritation and pain to the child. So regarding pain management, so as per the recent WHO 2012, previously we used to follow 3-step ladder. It is now 2-step approach. So for mild pain, like in grade 1, grade 2, one might use NSAIDs like acetaminophen or ibuprofen. And for all other moderate to severe pain, one has to resort to strong opioids like morphine. So it should be like by the clock. That is, it should be given at regular intervals. It's not like a SOS basis. So the child should be given regular dose of morphine. On top of it, one has to give rescue doses if he develops any breakthrough pain. So, but however, for in case of mucositis, we typically prefer giving intravenous and continuous infusions. And the dose of the um, morphine, if you're using, it should be decided and adapted to the individual needs. That is, once the child becomes pain free. For small kids, one can see and assess. Like for example, in this case, the child came with the drooling of saliva. So once his pain is better, there will be decrease in drooling. They'll be better able to communicate and talk. So these are some of the objective things that one can see when the child is admitted, and then take a call of hiking the morphine doses. So we always prefer for grade 3, grade 4 mucositis, admit and then start them with morphine infusion. Once the pain is better and once we achieve a standard dose of morphine, then one may consider shifting to fentanyl patch. So some of the facts that one should remember is whenever the opiates like morphine are used for acute pain control, it's not for chronic use, acute pain control, the addiction potential is very, very minimal in children. So one need not have a fear of that addiction potential, and then be very cautious in hiking the dose. One should be very liberal in giving pain medications. And sometimes a few kids may need very high dose of morphine, and sometimes they may develop even tolerance. So tolerance is not exactly equal to addiction, and we are always worried about some of the complications like respiratory depression, so which is very rare. As the child will be always admitted, one can always monitor and then hike the opiate dose rather than having a fear of respiratory depression. So good pain control from the beginning will lead to the better pain control overall. So one should be liberal in using pain medications and choose the dose and type of the pain medication according to the intensity of pain. We cannot judge. Sometimes they may have even grade 2 mucositis and have severe pain. So one has to go according to the individual needs rather than by staging them. So I'm not going into details. The morphine, whenever it is used in oral, typically we use IV. So when we use oral, the dose will be like 0.2 to 0.4 mg per kg for hourly. When we use infusion, we always have a fear of toxicities, and we start at very low dose. What WHO recommends is start at preferably at a reasonable dose, that is from 20 mics per kg per hour, and then titrate according to the need. There is no ceiling dose for this. Whenever the child has breakthrough pain, when the already on pain control medication, one might give a bolus dose or rescue doses of 10 to 20% of the overall 24 hours dose. And while weaning, when it is like short term, when we are giving morphine for less than 7 to 14 days, one might gradually wean. That again, while weaning, one should not wean very rapidly. It should be something like 20% of the original dose every 8 hourly. So few points on conversion from morphine to fentanyl patch. So there are some prerequisites. So the child should always be started on a strong opiates like morphine, whether oral or IV. And once he's tolerant and he needs at least 45 to 60 mg of oral morphine equivalent per day, one has to consider switching it to fentanyl. And the child should have a stable pain with the morphine for at least 24 hours before you switch on to patches, because these patches they have variable absorption and variable effect. So one has to find the adequate dose needed for a child. So the child should be pain free or stable pain for at least 24 hours before going for a fentanyl patch. And whenever you're using, it is available in various strengths. So always identify the appropriate dose. Appropriate dose, and then use it. Do not cut the patches, because they can lead to abnormal absorption and then even lead to overdosing. So whenever you are applying, it should be always applied on a clean area, dry, non-hairy. So probably we put on arms, over the shoulders, or back of the neck where there is non-hairy region. There one should put the fentanyl patch. And whenever you're putting fentanyl patch, there should be some overlapping period for approximately at least 12 hours till the fentanyl takes over its action. And it has to be either changed if you're changing or removed after 72 hours, and it should be applied on a different area when we are applying. Sorry, just a second. So my slides got stuck. Just give me a second.
Srinivas, just click once in the center and then uh, just do a click on the center of your screen.
Yes, sir, it's coming. So these are the equianalytic doses of oral morphine to fentanyl. When we have to change, we have to just look at the table and then identify the appropriate fentanyl patch and then use it. So one could see here that the minimum dose of fentanyl patch that is available in the market is 12.5 micrograms per hour. So the equivalent dose of oral morphine would be 45 mg. So that is the reason they say. So you have to establish one dose of morphine, daily requirement of morphine, then changes to fentanyl patch. So there are multiple other modalities for the treatment of mucositis, but none of them has been found to be very effective except for few. So coming to other case scenarios, so high dose melphalan. So here we have Master M, 3 years, case of neuroblastoma, high risk. His case of neuroblastoma, right suprarenal mass with anemic positivity. He got a rapid cojection induction, followed by underwent reassessment. He had a very good response, followed by he had tumor excised, and is currently admitted for high dose therapy with conditioning regimen, busulfan and melphalan, followed by stem cell infusion. So he underwent stem cell apheresis and got busulfan doses, and he's due for his melphalan doses. Any precautions that can be taken here? So we all know that melphalan can cause severe degree of stomatitis and mucosal inflammation, that is mucositis, up to the degree of 10%. So usually whenever uh, we give it the adequate hydration, and one can follow cryotherapy, but I'll go into the details of the cryotherapy now. And another scenario is when one is using 5-fluorouracil. So he's a 10-year boy, known case of nasopharyngeal carcinoma, stage 4C. So he was started on CCLG nasopharyngeal carcinoma protocol, which has a backbone of GPOH chemotherapy, which utilizes cisplatin and 5-fluorouracil. So here the 5-fluorouracil is given as a prolonged continuous infusions for around 4 to 5 days. So here the cryotherapy may not be feasible. So coming to prevention of mucositis in these settings, especially when one is using melphalan and 5-fluorouracil, these are the two drugs for which the cryotherapy has been found to be beneficial. But so whenever the cryotherapy is given, it is to be given for over 30 minutes before starting the chemotherapy. So it is indicated for high dose melphalan and 5-fluorouracil bolus doses, not for infusion doses. So I think the mechanism of action is it's quite understandable. The eyes, they cause vasoconstriction of the superficial blood vessels, and thereby it limits the delivery of cytotoxic drugs to mucosa and the reduction of damage. So, however, it is the cryotherapy is applicable only for few cytotoxic protocols which contain drugs which have short half-life or short infusion time. So, when we are using melphalan, it is actually short infusion. We can use cryotherapy and 5-fluorouracil, especially when you're using bolus doses, not for infusions. So, again, it has a pitfall that it cannot be used for very small kids. So, it can be used only for some older kids or adolescent because one has to hold the ice in the mouth. Small kids may not like to hold it for a long time. So I'll just run through few of the guidelines of a recent multinational association for supportive care in cancer guidelines, which mainly has robust evidence for only adult patients, not for pediatric patients, where few of these agents has been approved for use, like benjamin mouthwashes. Benjamin is nothing but an NSAID. So NSAID mouthwash has been approved for the prevention, and laser therapy, as we mentioned, it has been approved for adults, and also as there are quite a good promising results for pediatric patients, Pogo has suggested it could be used, but one has to consider that it needs expertise, special equipment, and cost. And the keratinocyte growth factors like palifermin is also indicated. And there is a suggestion that one might use, especially in adult patients. These are not pediatric recommendations. Honey and oral glutamine, they can have a preventive effect of mucositis. All the other agents doesn't have any recommendations as of now. When we come for treatment, there is no any single modality which can be used in the treatment of mucositis. So the recommendation currently stands only for morphine mouthwashes, which can be used in adult patients, especially who are undergoing radiotherapy or chemotherapy in head and neck malignancies. So sucral fat coating agent has been used. It has been found of no benefit, so it is not recommended. So I'll end the presentation with a small case. So this is a 10-year girl, known case of Burkitt lymphoma, stage 3, group B, high risk, received chemotherapy induction Arcopadam 1. On day plus 7, this child presented with fever. This child had fever, vomitings, loose stools, pain abdomen, and poor oral intake. On clinical examination, the child was looking dull, and her oral cavity had multiple oral ulcers with pseudomembranes, and bowel sounds are also sluggish. Her oral vitals were stable except for marked tachycardia. So here what we are doing is grade 4 oral mucositis with possible GA mucositis and probable neutropenic enterocolitis. So here one has to, these are some of the clues where one might need antibiotics upfront, and because the oral bacteria or gut bacteria, they could be both gram negative and also gram positive, especially in oral mucositis. There will be oral commensals like Viridans group of organisms, streptococci. One has to give both the gram negative and gram positive cover when we are adding antibiotics in such kind of clinical scenarios. So thank you. So I stop presentation with this slide. So in simple, it is mostly applicable for high dose methotrexate. Mucositis, two-pronged prevention and treatment. So preventive strategies that as per protocol one has to follow: meticulous hydration, alkalinization of urine, folic acid rescue, and monitoring with both clinical parameters and also lab parameters with creatinine and methotrexate. These are some of the modalities which has found some benefit in pediatric. So when available, one may use it, but practically this is not possible in our settings. And while discharging, this is the utmost important thing is oral care. So we give them appropriate protocol or whatever to maintain good oral hygiene, and explain them the warning signs. And always we should tell them to come back once the mucositis signs comes. When we are dealing with mucositis, so grade 1, grade 2 can comfortably managed in outpatient in most of the cases with adequate basic oral care and local analgesia if needed, oral opioids, and prophylactic NG insertion, and ensure adequate hydration. And they have to be monitored regularly, maybe everyday visits to look for any progression of the mucositis and need for admission. Once it is severe mucositis, the child needs inpatient admission. With the same, we have to continue basic oral care, hydration, and good analgesia, and assess for the need for a TPN. Once it's comfortable, you can start elementary feeding and oral decontamination procedures. So dose modifications, I'll not be going in detail. It should be followed as per the protocol or individually depending upon the child's clinical status. Thank you.
Um, Thank you, Srinivas. I think he's covered more or less the most important aspects of mucositis, and we have to remember that he's already said that it's just reiteration of the same fact that once mucositis occurs, it's a supportive care, and you just have to wait for the cells to come back. Until the cells come back, you have to ensure that the child is pain free, your mouth is looked after so you don't get more infection mouth, and I mean obviously if it's spread to the gut, etc. And you have to look after the hydration and nutrition, and of course if there's infection, cover accordingly. So with this, I think Srinivas, are you there? Yes.
Yes, ma'am. Yes.
There were a few questions in the chat box. I think I've sort of kind of added, answered some. And the last one which came was Nicola has asked on the role of prophylactic NG tube insertion. Now, what that means is that if you have a patient who's come, and what you will not put in a tube if the child has stage 4, or I mean advanced stage mucositis 3 or 4, because at that time, in any case, your mucosa is going to be very friable. Putting in a tube could cause more damage than help. So it's when in the early stage of mucositis, if you're thinking that this child is unlikely to recover in, of let's say in a few days' time, and you think it's going to end up being severe, that is again, it's a clinical decision. And if your child is already, a sort of a on the borderline malnourished state, then it's easier to put it in the beginning rather than wait for it to advance. Like if a child has got high dose methotrexate or any then, and plus if he's had it earlier, one previous episode, he comes in, he's already kind of borderline nourished, so you know he's coming to you in clinic and you think he might need end up getting admission the next day, you put it in. It depends on your disease also. A person who's a Burkitt's lymphoma, you know the mucositis is going to take longer to recover, so you will put in a tube. Similarly, in a transplant situation, when they're getting mucositis, you'll put in a tube because you know very well that they're not going to recover in a couple of days time. So it is a clinical situation which will guide that yes, do you need a NG feed or not. Mild mucositis, if he's on something like a PITC regime or something which you know it's unlikely to be a severe mucositis, then you can let it be. But in any situation where your clinical judgment will overtake that yes, this child is not going to get well in the next, let's say, 48 72 hours, so it's better to preempt, because once you've gone into a severe his counts have crashed further, his mucositis has worsened, you will be unable to put it in, which is what I think in the early stage when he said in early mucositis, this is what he meant by prophylactic NG insertion. And I hope that answers your question. So this part you said metrogyl role in mucositis induced diarrhea in a patient who was already on this is a clinical decision. The child is having mucositis, you know he has diarrhea. Now it is very difficult to differentiate that is this diarrhea because of mucositis alone or it is because of an infection. Fever would help you, yes, definitely, but 80% or 80 to 90% of the time, a child who's having mucositis induced diarrhea will go on to antibiotics, because there is really no way you will be able to differentiate that is this just pure mucositis alone or is it because of the a superadded infection. Point number one. And number two, I think this question was asked earlier, that you have a breach of mucosa, and that in any case is going to result in a very high risk of infection, and your host is immunocompromised, which once you get a bacteremia, it can put you to life-threatening sepsis. So therefore, you would most patients who get mucositis will end up going on to antibiotics once they get diarrhea, etc. And metrogyl again, it will end up being sort of a clinical decision. You say you will send your stool, etc., and take a call that yes, do I need to add metrogyl or not. I think these are the questions. Please add on, everyone. And cryotherapy, in somebody had asked in transplant situations. Now, Sunil is sitting here, so for a transplant situation, I think I would not answer the question, I will let him answer it, because to my mind it's not easy sucking on it, and there are no really hard and fast recommendations for this.
No, I think, ma'am, Srinivas has explained it very well. I think the question was before he spoke about it. It is definitely indicated for short infusions where the half-life is short, and practically it's useful only with melphalan used in conditioning. And it is sometimes challenging to feed small babies ice cubes, but we have kind of worked it around. We make candies which are juice candies, and they put it in the freezer one night before they suck it. Sometimes they use ice creams also, just to lower the temperature of the buccal mucosa for that 15-20 minute infusion. So it's not too difficult, and kids do love most of it. If it's a flavored candy, they do love it. uh, uh, you know how much would be that effective was vis-a-vis if it's done by adult, we really don't know, but it is feasible and it's done for melphalan conditioning. That's probably the only conditioning agent where we are using cryotherapy at the moment. Ma'am, couple of questions I had. One is that extract from the question answers in the chat box only, and that is leucovorin rescue with what do you call this with respect to the oral mucositis. So what are your thoughts, ma'am, on extending leucovorin rescue, especially if someone has already had had previous episodes, the first infusion, for example, given for a longer time, pros and cons is a very common question which is asked,
Yeah,
the pros and cons of
I,
extending the leucovorin rescue, and
I
till how
totally.
long will you give it?
I was trying to kind of avoid any too complicated an answer. Yes, I agree with you that. See, now there are some studies which say that if you give too much of leucovorin, you might be kind of counteracting what your methotrexate does. But like you said, I think again, if a person has had it earlier, and we know possibly because of his creatinine, etc., he's probably one of those people who's a poor, he doesn't clear his methotrexate very well. Yes, you could increase, but then the situation becomes how much do you increase by? Because most places now will say that yes, about 6 doses is sufficient. You don't need to go into, I think a lot of earlier studies had put 12 and 15 doses. So possibly depending on that, one could take a call that yes, you increase by 2 or 3 doses. But again, I think I would leave that to the clinical person's judgment. But I agree with you that yes, if the previous situation has shown, high dose methotrexate, he's had 1 or 2 cycles, and you are facing the same issue, yes, probably it would be prudent to increase a bit. But I would also like to add that the hardcore leukemia experts will probably say, think about it 10 times and insist that no, you get a methotrexate level, go accordingly. However, Saksiaram had asked, yes, methotrexate levels are not easy to come by in India. So I would advise all of you not to get too stressed about it. I have used methotrexate for a good 10, 12, 15 years before we were able to get levels, and I do not think we had such. This is published. If you go through, this is published from our institute, and it is feasible. So please don't stress if you're not able to get it done. Just go by the fluids and the creatinine. And of course, always remember that if once the first time around when you're given high-dose methotrexate, the child has had issues, you're a little more warned the next time around. So you will be ultra careful the next time around to ensure that he gets a little extra fluid. And instead of the usual 72 hours, you can extend it to 96 or even higher, so that toxicity does not occur. That's what I would feel.
Ma'am, two more questions. One is
Sure.
role of, I think again Srinivas touched it briefly, a role of these mouthwashes like Cafesol. So I think
Yeah.
still debatable. So ma'am, what are your thoughts on that? And number one. Number two is alcoholic mouthwashes, of course, to be avoided when you have mucositis already. But what about chlorhexidine mouthwashes?
Srinivas, you want to take this up?
Yes, sir.
Yeah.
Sir, one is regarding this Cafesol. So as I mentioned, it came into market with good evidence from RCT that it decreases prevents some mucositis. But the COG has the recent study, and there's like the evidence is like conflicting. There is one Taiwan study also which has told that capsule is beneficial in preventing mucositis, more in severity and the duration. So cost is the main hindering factor because we don't have so much of studies, but COG is definitely told there is no benefit of capsule. If cost is not a barrier and one could get, then one may use it because it's like any other solution. It's not going to something uh, change the course. So same thing has been observed with the good basic oral care approaches. That is, they say it is the very key for preventing rather than going behind the basic solutions or antimicrobials or antiseptic solutions. So maybe good rinsing with the normal simple salt water or bicarb also may do well. And regarding this chlorhexidine, as I mentioned, alcohol-based are definitely be avoided. And for prevention of mucositis, definitely no role of chlorhexidine mouthwashes. But yes, for preventing infections when the child gets mucositis. So that is like debatable. So one can use chlorhexidine alcohol-free, no harm in using. One can always use, though the evidence is like conflicting. Chlorhexidine mouthwash can be used provided it doesn't contain any alcohol content for prevention of mucositis.
Thank you, Srinivas.
Regarding the extended dose of leucovorin, so it all depends upon how severe the mucositis at the initial period, and was there any abnormalities like say he had any rise in creat initially, which was managed with adequate increasing hydration. So those kind of picture and maybe then delayed methotrexate clearance. Maybe sometimes it may take time at 42 hours or 48 hours, the levels may get normalized. And despite all this, if you get severe mucositis, one might consider giving extra doses. Yes, I agree. There is always a debate whether it can harm the tumor activity. But there is also say that the timing for leucorin going to stay the same. So it may not hamper the methotrexate activity so much. So giving 2 or 3 doses extra may not actually be harm in such cases. It has to be individualized, of course.
Any other questions? Anyone has? I think most of has been dealt parallelly in the chat section. Any other questions anyone has?
I just answered one on betadine. Doctor,
Yes, yes,
I think Edward is, sorry, some D5 ward.
yeah.
So betadine, yes, people have, used it in the past, but you have to really dilute it considerably because you cannot, I think the gargles which are available may be diluted, but to be honest, I don't think any child will take it. It's not easy to ask some, little person to have betadine. Mouthwash, it tastes like crap. It's the same as, the children when we give them potassium. I don't think 50% of them don't take it, so this will be the same thing. For gargles, the easiest for a child is simple warm water or simple salty water, which the mother can make at home. 1 glass of water and a little bit of half a spoon of salt or soda bicarb. That is the easiest to do. And we sometimes see children who will even refuse a little bit of salt water because for even if you have a little bit of mucositis, please remember there will be pain. So just simple warm water gargles is also fine, especially the little ones. They won't take anything which they which they don't want. We all know that we're pediatricians. Children will refuse. So you have to be practical. So if they're not taking anything for mouthwash, you tell the mother just let him. Even if he, small for people will not understand swish and spit. So just tell them to sip warm water. So warm water will automatically clean his mouth. You know. So you have to be a little practical and sort of weigh the pros and cons of how to do it. I hope that's okay. That's clear. Thanks.
Ma'am, I think there are no more questions, and I should thank you for your time and really taking up this topic, which is so common, and I think so much gray also at the same time, and makes the quality of life of our kids so bad at times, and not only the kids but also the extended families. I think we have stressed very nicely that prevention is better than cure, and we need to make every attempt in prevention as much as possible. So thank you very much, ma'am, for your time, and thank you, Srinivas, for a very wonderful of wonderful covering the
And
topic.
thanks to the participants for the very
For
active
the
interest
interaction.
in the topic. Yeah.
Yeah. So we'll log off then, and we'll see you again next week. Thank you very much.